In both type 1 diabetes and type 2 diabetes, the treatment option have advanced tremendously. Preconception counseling should be discussed at every single visit.
All right. Hello, everyone. My name is Dev,
And my name is Caden.
and today we're here at the Diabetes Roundtable, and we're part of a student-led nonprofit organization, Relief Care Foundation, and we aim to provide support to people with diabetes worldwide through widespread access on social media and other platforms, such as the podcast like this one. So today we're really lucky to be joined by Dr. Basina, who is a board-certified endocrinologist and clinical researcher at Stanford, specializing in diabetes care, diabetes technology, and endocrine disorders. She also serves as the medical director of Stanford's inpatient diabetes programs and has received multiple awards for excellence in teaching and patient care. So, Dr. Basina, if you want to introduce yourself in a little bit more detail.
Okay, sure. Thank you for inviting me to participate in this podcast. I think it's very important to raise the awareness of diabetes and to sort of send a message to the patients with diabetes that they're not alone, and they get a lot of support from the community and their healthcare providers. I am Marina Basina. I'm an endocrinologist, as you mentioned, clinical and research faculty at Stanford. I did my fellowship also at Stanford and had been on faculty for close to 20 years. I have been leading several clinical trials and involved in different NIH consortiums related to diabetes care. Also, I am a member of large national organizations and a board member of organization Breakthrough Type 1 Diabetes, that is former JDRF. I'm also a member of a QI Collaborative of Type 1 Diabetes Exchange, and that is also a great national organization. And I'm on medical advisory board on several community diabetes organizations. As you mentioned, I do specialize in diabetes technology, more type 1 diabetes and diabetes in pregnancy.
Yeah, so obviously you have a lot of different awards, different specialties that just prove and serve as a testament to your credibility and your healthcare work that you've done over the past many years. So now just to kick off the conversation portion that we have prepared for you, some questions that our viewers would love to know. So our first question begins with, what originally drew you to endocrinology and diabetes care specifically?
I always felt that endocrinology is a very physiologic field that involves the interaction of the hormones and interplay of hormonal and non-hormonal function of endocrine organs that affects the whole body. For diabetes, I was initially during my fellowship, I was debating which subspecialty of diabetes to go to. But then I saw how much of the unmet needs in a diabetes field, and not only medical field, but also psychological support of those patients. So that kind of more convinced me to subspecialize in diabetes, and again, more so in type 1 diabetes, but also I do general endocrinology as well as part of my practice.
Well, yeah, it's cool that, everyone has different pathways to the medical field and, they end up where they do. For example, I mean, the reason that we started our nonprofit organization was to sort of bolster the community support of diabetes, and also because we have familial connections with diabetes. For example, my dad has diabetes, which is more of a reason I want to explore in this field. But still, it's great that everyone has different pathways to medicine or just diabetes and healthcare in general. So that leads us to our next question, which is, you've worked in diabetes care for over 20 years. So how has treatment changed the most over time in your eyes?
Yeah, so in both type 1 diabetes and type 2 diabetes, the treatment option have advanced tremendously. If For if we start with type 2 diabetes, which is the most common type of diabetes, we have so many new classes of medications that are not only beneficial for diabetes treatment, but also reduce risk of cardiovascular disease, reduce burden of diabetes and of complications, reduce progression of early stages diabetes complications to later stages such as kidneys and heart disease. Um, Also provide the options of decreasing blood sugars with at the same time helping with some weight loss and also reducing the burden of insulin resistance and again reducing the risk of cardiovascular mostly complications. That is uh, the main complication or burden of mortality and morbidity for those individuals. So now we have so many different classes of drugs that we can use comparing to when I started practicing in this field. For type 1 and type 2 diabetes, we have amazing progress in terms of the developing of diabetes technology. When I started, I remember my first year of practice, the continuous glucose monitoring device was a 3-day duration sensor that was placed in the office. If individual had to take a shower, it was a special shower bag that they had to place this device in. Um, and it was quite sizable device and it was not a real-time sensor, so we had to, after patient had worn it for 3 days, they were bringing it to clinic and we downloaded and evaluated the patterns of blood sugars. So again, the data was, as you can imagine, very, very limited, what we were able to see. Comparing to fast forwarding to today, now we have tiny devices that are worn for 15 days that measure readings of sugars every 1 to 5 minutes, providing as 5 minutes, providing as 288 readings per day. And identifying the patterns, we can follow those patients either in real time and they themselves can see sort of their feedback on the glucose control every 1 to 5 minutes, depending on what sensor they're wearing. So the devices are very, very small, easy to use. They're waterproof and resistant. The individuals can swim with it, can take showers. They are very, again, size is so small that they're barely visible. So it would be easier for patients to hide if they are not willing to disclose the information about their diabetes to their um, uh, to work or to their social media where they're participating in. In addition, now we have from technology, we have insulin pumps. Again, previously, insulin pumps were not connecting to the sensor, and we had to program the settings, and those settings needed to be adjusted based just either on the finger sticks or those sensors that were not connecting to the device, to the pump. Now we have automated insulin delivery when pumps and sensors talk to each other via Bluetooth and algorithm that are embedded in the pump or on the phone app are calculating every 5 minutes what dose of insulin needs to be delivered based on what the current blood sugar is, what it projected to be at different time intervals, depending on what system is being used. Um, and they are either decreasing or increasing insulin doses for patients if blood sugars go up or down, or completely suspending insulin delivery if they're predicted to have hypoglycemia. So those developments in medical field are amazing. They're reducing so much of the patients. Still, patients obviously need to be very involved in their diabetes care, but it significantly reduces that fear of hypoglycemia reduces, have been shown in studies, reduces the risk of diabetes complications and just makes it so much easier to control blood sugar compared to what we've had before.
Yeah, so as you've just said, there's been like a lot of advances in diabetes care, with continuous glucose monitoring, all of that. So for someone who just got diagnosed with diabetes, what would you say is one of the first things that they should do or know early on?
So it depends obviously what type of diabetes that is. For type 2 diabetes, it's important for both types, I would say. It's important to get on top of its treatment right away, as soon as possible. I always try to send message to all my patients is that unfortunately diabetes has this legacy effect. What that means is whatever your diabetes control in the first few years, that is affecting your complication rate for the rest of your life. So if someone is not controlled for the first 5 to 10 years, then but becomes very well controlled, let's say 20 years into diabetes, but at that time start developing all the diabetes complications. And I hear this always in clinic. I am so well controlled now. Why is my body is getting into all of those complications of diabetes? And it's really hard for me to say that is unfortunately it's because for the first 5 to 10 years that diabetes control was not good. And there's no turn back the clock, unfortunately. So it is what it is. So it is a very extremely important to start taking care of it from day one, from the diagnosis. I can't emphasize how important this message is to all the individuals with diabetes, any type. Now, for type 2 diabetes, because onset is insidious and individuals who are diagnosed with type 2 diabetes might have had pre-diabetes or even undiagnosed diabetes for quite a long period of time, we already aware that some patients, even with newly diagnosed type 2 diabetes, may already have some diabetes complications or close to manifest those complications. That's why it's important at the time of the diagnosis to get all the screening tests for any of the complications that might have had already developed in the stage of their prediabetes or undiagnosed diabetes. Comparing to type 1 diabetes, because it's usually an acute onset, we usually don't see any complications for at least 5 years. But again, the control of that first 5 years is what sets up the health for the rest of the life.
Yeah, and obviously, there's different cases of diabetes. One of them, two of them, like you mentioned, are the type 1 and type 2 that are probably the most prominent in the world. But also, we want to look at another group that you also highly focus on, which is women when it comes to pregnancy. And just what are some important key points that you would love for women with diabetes who are pregnant that they should know about when during the duration of their pregnancy?
Yeah, of course, this is a a very important topic, very kind of dear to my heart, because I have been involved a lot in diabetes and pregnancy. Again, there are great community resources and groups for women to participate in. One of those called Sugar Momas, type 1 diabetes, but it's MOMMAS. So if you spell it wrong, you get to the kind of weird websites. So if it's Sugar Momas type 1 diabetes, if you just Google it, you get to a Facebook group that now includes, I believe, close to or about 1,500 women all over the world. But what it is important is for someone who is at risk for diabetes, either have significant family history or had prior history of gestational diabetes with prior pregnancies or pre-diabetes or any kind of glucose abnormalities. It's very important to evaluate blood sugars before getting pregnant. because the organ formation happens in the first 5 to 6 weeks. It's usually the time when women not even aware that they're pregnant. And that is a very important time of very good glycemic control. So that's why it's now American Diabetes Association emphasizes that preconception counseling should be discussed at every single visit of women of childbearing age, and to make them more aware that how important this topic is. For someone who has pre-existing diabetes, it's important to get glycemic control to target before pregnancy, again, because of that important point that actually the most important time of the pregnancy, not the most important, but I would say extremely important, is when all the organ development occurs in the first half of the first trimester. Women who were diagnosed with diabetes during pregnancy may have either gestational diabetes or undiagnosed type 2 diabetes, or non diagnosed type 1 diabetes. So either of those conditions are possible. Women whose diabetes resolves after delivery still at a very high risk for developing type 2 diabetes. So the risk is about 50% in the next 3 years. So it's very important to follow up and to get the appropriate tests done to make sure that diabetes is not persisting after the delivery. And then with subsequent pregnancies, again, there is a higher risk of gestational diabetes and type 2 diabetes.
Yeah, yeah. So, throughout you said, there's a huge importance on taking care early, just sort of focusing on health, physical status, but there's also like the mental status. So, how important is that mental health when it comes to managing diabetes?
Yeah, so mental health is very, very important because the mental state or the mental health affecting the diabetes control significantly. If person has So we are trying to implement, actually, in our clinic there is a diabetes distress survey, which is good for all the patients for diabetes to take and to just see how much diabetes is affecting their life psychologically. So diabetes, unfortunately, is a 24/7 condition that doesn't go away usually, and it's important in every aspect of person's life. It's day and night, with no day offs and no vacation time. So that's why it's important to have positive attitude, to know that you're not alone, to know that there are a lot of support groups and healthcare. We have psychologists who specializing in diabetes and in different types of diabetes, and the community involvement is extremely important.
Yeah, yeah. So just before we quickly move on to our myth and fact section, just one last question that we wanted to ask. So looking ahead in the next 5 to 10 years, how do you think diabetes care is going to look compared to today? How do you think technology is going to evolve?
So it's a good question. It's hard to say where exactly. So obviously, what we're trying to focus on diabetes cure. So that's the goal. Type 1 diabetes, it's a huge burden for individuals. It's a lot of the variability in the glucose control. One day could be perfect, the other day could be disaster with exactly the same insulin doses and doing exactly the same what individual had been doing yesterday and today. Therefore, obviously, cure is the goal. We are trying to work in several different ways for improving care. So, one is trying to improve diabetes technology, try to automate the insulin delivery. Current systems that we have are hybrid closed loop systems, meaning that individuals still need to announce their meals, still need to kind of estimate their carbohydrate count in grams or portions, and enter that into the algorithm for our algorithm to be able to calculate the dose. The goal is to reduce that burden of entering this data and to create this fully automated closed loop insulin delivery that will be self-adjusting based on the glucose trends and delivering insulin without individuals' input. Again, this is in development, and unfortunately, insulin is not the only hormone that's missing physiologically in any diabetes, type 1 or type 2. So we have now a lot of different, what we call adjunct therapies that are working in, so along with the insulin to improve the glucose control and helping with other functions, because insulin is delivered not in the physiologic space, like, right, is delivered subcutaneously, not where the body intended it to be delivered to. So in terms of the oral medications as well as injectable non-insulin medications, there are many medications are in the pipeline that improve glucose control, reduce the frequency of the administration of those medications, providing more sustainable control without weight gain, without low blood sugars, and at the same time reducing risk of complications.
Yeah, and just to branch off into our next section, which is our myth or fact, where we'll read out a statement and then you can elaborate on whether it's a myth or fact. And like you mentioned earlier, just now in your response, you mentioned something called closed loop insulin systems, which actually leads perfectly into our first statement, which is closed loop insulin delivery systems are close to creating a fully hands off experience for people with type 1 diabetes. Myth or fact?
Um, the fact that it is in development, but at this point, it's still a myth.
All right. So I'll ask the next question. Continuous glucose monitors can improve outcomes, even for some patients who don't use insulin. Myth or fact?
Fact, yeah.
And then the next one is the stress and burnout associated with diabetes management can affect blood sugar just as much as diet and exercise.
Yes, absolutely.
Okay. So I think we touched on this a little bit earlier, but just wanted to sort of bring it back just because it's a very important topic. Pre-diabetes should be treated just as seriously as diabetes itself.
Yes, absolutely. Because we know that over a third of the patients with prediabetes already can develop the complications of diabetes.
Yeah, and then just another question is sleep quality has a measurable impact on blood glucose control.
Yes, absolutely.
Okay. So I guess we'll do one last question before sort of closing off. But do most patients have the access to, especially the newer technology when it comes to diabetes, including continuous glucose monitors, newer insulin pumps, all of that?
Yeah, that's, I think, $1 million question. So we are obviously struggling with some of the insurance plans to approve certain diabetes technology. Um, I would say it depends on it depends on the insurance. The good thing that the coverage for those devices is significantly expanding across all the insurance plans, including Medi-Cal and Medicare, which is very encouraging and promising. There are some choices of some of the devices that may or may not be covered by some of the insurance plans, but in terms of the um, technology, that's definitely expanding the indication and the coverage from the insurance. Does everyone, every single person with diabetes has access to it? Definitely not. And unfortunately, technology is still quite expensive, and some individuals may have significant copay that they're not able to afford. There have been delays in the insurance coverage. Some patients have lapses in their care due to that. As we know, now it's a difficult time, and a lot of people lose their jobs and lose their insurance coverage, and they are starting rationing their insulin as well as the use of their insulin diabetes supplies, which is very unfortunate. And I think all those patients have to have equity in using any of the technology that is basically needed to sustain their health and their life.
Yeah, I mean, I think that just perfectly sums up what, what modern technology has to offer, but also just some shortcomings that technology can also come with. For example, not everyone being able to have access to the top-notch healthcare technology that is developing right now. But yeah, I think you hit all the points that our viewers would love to know, and we have a lot of new answers to questions that we've been wanting to ask to healthcare professionals like yourself as well. And yeah.
Yeah, so this is just one last closing question that we like to ask. If there was one thing that you could tell all diabetes patients, what would it be?
One thing I would say, never give up. Even if you have a bad day and you feel like your blood sugars are completely out of whack, it's just that one bad day, and tomorrow would be a better day. And definitely, we're striving to find the cure for all types of diabetes. Not sure at our lifetimes or your lifetimes it will come, but comparing to what we've had 20 years ago when I started, this has been absolutely amazing progress. And that also you're not alone and you have lots and lots of support.
Yeah, yeah, that's very true. All right, then. I think that's about it for this episode. Thank you so much for your time. Um, and yeah, I guess we'll end it there.
Thank you.
All right, thank you.